Hello, everybody. It's my first time in a Congress of Neuropediatry, and I think this is a very good idea. I will come back. This is my disclosure. I'm sure that you all know what is ADHD, of course, because it is a very common disorder and somewhat not so complicated. But just to be sure that we speak about the same thing, a couple of things. First, many people say that ADHD is a new disease. This is not true at all. We can find very old textbooks where the disorder is very precisely described, especially the book of Christian, but even before. And the two facets of the ADHD are inattention on one side, and on the other side, hyperactivity, impulsivity. And you know, this is a little bit like schizophrenia. You know, in schizophrenia, there are positive symptoms and negative symptoms. And at the very beginning, psychiatrists were obsessed by positive symptoms because they raised the most spectacular problem. And nowadays, negative symptoms are even as important or perhaps more important than positive symptoms. And we have probably the same thing with ADHD. In the past, hyperactivity was the main problem. And even we talk about hyperkinetic disorder because hyperactivity is the problem for the teacher and the parent. And nowadays, we realize more and more with longitudinal study that inattention is likely to be the real problem, especially in girls, and because it is the predictor, the most important predictor for a bad outcome in school, especially late in school. So inattention, hyperactivity, impulsivity, and a couple of other things. Of course, it has to begin early. You can have some adolescents onset ADHD, but it is very rare, and you have always to think about other diagnoses. It has to be present in two settings. Most often this is the case. Sometimes you can have a kid with ADHD only at home, and in this situation also you have to ask questions about why only at home, of course. The interference with functioning, and this is likely to be the real problem, because what is the definition of an alteration of functioning? Obviously, it depends on the level of expectation you have with functioning. And this will be a problem for epidemiology and for clinical practice. We will come back to that later because this is crucial. And of course, it should not be explained better by another mental disorder, even if this is tricky, because you have a huge comorbidity between ADHD and another mental disorder, autism, for instance. And this is a clinical question. Do we have to treat ADHD in autistic patients, etc., etc.? So this is the global picture of the diagnosis. Georg told me, you will be with neurologists, you will have to speak about pathophysiology and all those sorts of neuromediators, etc. I don't know even the beginning of a notion of that, of course. As a public health professional and as a psychiatrist, my culture in neuroscience is very weak. But as a naive observer, I can give you my impression. My impression is that ADHD should be very close to a neurologic disorder. Why? Because, first, it is a rare disease in child and adolescent psychiatry where the placebo effect is very small. And the other point is that we have medications, stimulants in particular, and the effect size of this medication is huge. Stimulants have an effect size which are likely to be the most important effect size for all psychotropic drugs. You can take 2 times 30 patients with ADHD. You compare methylphenidate with placebo, you will have a p-value smaller than 0.05. And this is very rare. even in cardiology, in cancerology, etc. So if medication have a so important effect, if placebo has a so small effect, this is very likely to be a so-called somatic disease. And even we had some rather simple mechanism of action of the disease with the concept of frontostriatal dysfunction that we had in textbook in the last decades. And there has been many pathophysiological studies in ADHD, and now I do not understand anymore what is this disease. Because when you do brain imaging, you can find problem everywhere. When you try to see what are the problems as regards neuromediators, this is exactly the same. Before there was only dopamine, and this was simple because the medication are dopaminergic. So for me it was simple, and now I listen that there is no, of course there is the problem with dopamine, but also with many neuromediators. There is a high level of heritability when you compare monozygote twins and heterogeneous dizygote twins. So there is an important heritability, but no major genes. Everybody agree with that? And a high level of gene-environment interaction, which means that the notion of heritability becomes very awkward. So, in the past, the pathophysiology of ADHD was simple, and today it is no more. Concerning epidemiology, what is the prevalence of ADHD? If you look at the literature, you will have a lot of papers in various countries, even meta-analysis, and you have a very recent meta-analysis that has been published in May, and the answer is 7.2%. Okay, but is it reliable? What does it mean? Is it reliable? I would say yes and no. Yes, because the diagnosis of ADHD has been operationalized in the DSM, in the ICD, but the definition in the DSM is the most used. There are epidemiological tools that can grasp this definition of ADHD that is in the DSM. It works on a statistical point of view. It works. You have inter-rater agreement, test-retest, interreliability, etc. It works. And so you can say that this figure corresponds to something, and even that the prevalence is not so different across countries. There are differences, of course, but not so important. So on one side you could say, of course, okay, the prevalence of ADHD is about 7%. But on the other side, as I told you, the main point is ADHD. There are two main points. The first one is the phenotype, which is at first sight easy to grasp. But on the other side, there is a level of impairment, which is very, very difficult to grasp in epidemiological studies. And there is a huge variance about impairment across country, because the structure of family, the type of teacher you have, and even more smooth sociological concerns like authority, etc., will make that the impact of the same phenotype will be very different for the kid or for the adolescent. And so, the prevalence of ADHD in this aspect will change a lot. And I like a lot the paper that Spitzer, who is a very famous American epidemiologist, wrote in the Archive of General Psychiatry, now the JAMA Psychiatry, which is a very good journal. Diagnosis and need for treatment are not the same. And I would add epidemiological diagnosis and need for treatment are not the same. That is, yes, prevalence of ADHD on a scientific point of view are reliable, but no, it does not mean that 7% of the kids and adolescents have to be treated. This is a very, very important fact. And so I think that something very interesting, more than the prevalence of ADHD, It is the prevalence of stimulant consumption. Because here the definition is very simple, and you have data. And what you see, as you know, there has been a very sharp increase in the consumption of methylphenidate in particular and stimulants in general. In the US, it has increased up to 2000. It is supposed to be stable, even if you can see that between 2000 and 2011, it has gone from 5% to 7.5%. So the increase is still here. And you see that it is 7.5% for male and female. And you know that the prevalence of prescription is much higher in boys than in girls. And so the prevalence of consumption of stimulants in the US in boys age of 10 years old, which is a peak of consumption of methylphenidate, is likely to be higher than 10%. I don't say it is bad or good. This is another question. What I say it is very high for a medication that is taken every day and for several years. And which is completely crazy if you look at France, which is a country rather similar to the United States in many aspects. You can see that the prevalence of consumption in 2013 was only 0.7% in boys. In boys. That is, the prevalence of consumption of methylphenidate in France is likely to be 20 times smaller than in the US. And I don't say that it is good or bad also. You can see that there is obviously an impact of something which is sociological on the way we treat patients with ADHD. And I will come back to that, of course. So why? What can explain these differences? I told you that the phenotype of ADHD is simple. In fact, this is not true. This is not true. And you know, I like this sentence. This is an American author. When you have a hammer, and when you have a good hammer and it works, you are very pleased to see nails everywhere because you can use your hammer. And this is exactly the same with methylphenidate for child and adolescent psychiatrists. This is a hammer. It works. And you know, in child and adolescent psychiatry, this is not frequent that we have medications that work. So we are very proud to have a very good medication. And so we are looking for ADHD patients everywhere. Because on a narcissistic point of view, it is so good to prescribe and to see the family after who say, "Oh, it is fantastic, my kid is completely changed, it is a revolution." And so, there is a temptation to, and of course, on the other way, you know, there has been a paper in the Lancet which had shown on epidemiological data that there is an association between ADHD in kids and mortality by accident. Mortality. So this is serious. We have to treat ADHD because there is a question of mortality. So this is a serious problem. But because this is serious, because we have a hammer, there is a temptation even more to look at nails everywhere. After, the phenotype of ADHD, in fact, varies according to the family, the school, the IQ, small IQ or high IQ. Small IQ, because of course, due to the development difference, of course there is inattention, of course. And high IQ, because kids with high IQ want to learn a lot, and they are bored. When you speak slowly, when the teacher speaks slowly, they are bored, so they do not listen because they are already understood what the teacher told. And it could seems to be inattention. The level of expectancy, as I told you, and this is a very, very important problem in our European countries because more and more parents have high expectancy at school, and if the kid has even a very small level of a so-called inattention problem, they will bring him or her to you saying he should have marks very high, he has a very good potential, he has only average mark. This is a problem of functioning. This is a problem of expectancy. And we are in a difficult position. I will come back to that. Trauma, of course, trauma. Emotional dysregulation, of course. But here, there is a very interesting clinical point. When you have, especially for kids with ADHD are curious. They are pleasant, in fact, during the consultation. Because kids with ADHD are curious of everything, and in particular are curious about people, and are curious about you as physician. They will look at you, ask you questions, they will find you behind the desk, etc. And when a kid has a trauma or depression, etc., with behavioral problem, they are not like that. The question of attention, it could seem something very simple. You know what? Problem of attention. I cannot concentrate, and that's all. In fact, you know that the definition of attention in cognitive neuroscience is not that simple. Attention, it is the problem to focus consciousness. But what is the definition of consciousness? There are cognitive neuroscience of consciousness, but you know that this is not completely fixed at the moment. So even on a theoretical point of view, attention is not so well defined. And even on a clinical point of view, sometimes you have a kid that is proposed to you for your consultation for a so-called problem of attention, but in fact this is not ADHD, this is a patient who dreams. At school, the teacher says, well, he does not listen to me. He is not able to listen to me. Yes, of course, he is not interested by the teacher. He is thinking to something else. He is able to think and to dream and to live inside his mind. And so it can seem to be inattention. Well, in fact, it is a dreamer. And it can be a problem, on an ethical point of view, to treat dreamers with stimulants. Another point is that this is a very basic clinical problem. It is much more simple to say to parents, yes, your kid has ADHD, yes, I will propose you something which is an efficient medication, than to say, yes, your kid has something that could look like ADHD, but it is not severe enough for me to propose you to take the medication. This is very difficult to say that. This is very difficult to say no to parents who bring you kids for a problem. Because as you know, psychological treatment are not so efficient in ADHD. And because of that, because of the hammer, it is very tempting to say, yes, I shouldn't prescribe, but it will take me 15 minutes to explain why I say no, and I am in late, and so I say yes. And so, as you can see, this is not the concept of ADHD is not so easy, and of course, this raises methodological problems for studies, epidemiological studies, genetic studies, brain imaging studies, because if the phenotype is not so clear, the inclusion criteria are loose, and so there is noise in the data. But there are also clinical consequences which are very important. And so this brings me, this is my one of my last slides. This brings me to speak to you about the other side of ADHD. First point, this is a classical question, especially when we treat children and adolescents. Are we treating disease or patient? And for ADHD, this is very important. Everybody will say, I do not treat disease, I treat patient, of course. And so, but ask to yourself, what is your definition of a patient? What is your definition of a patient? You can ask this question to your students. You will be very impressed by the answer. Most often, they say, well, a patient, it is somebody who has a disease. And we know what are diseases, ADHD, epilepsy, etc., stroke, etc. While in fact, of course, as you know, a patient is not defined by a person who has a disease. It changed from country to country, the definition of a patient. In my country, the definition of a patient, it is the person who is ringing the bell of a physician. It is Georges Canguilhem, le normal et le pathologique. The definition of a patient comes from his complaint. And you can understand that in psychiatry this is very important. Basically, we shouldn't treat people who have no complaint. Basically, of course, we are obliged sometimes. But we know that in the past we treat homosexual people. And of course there was no complaint most often. And it was a very, very, very big mistake. So we are afraid to treat people without complaint. But the question with ADHD is that nearly always there is no complaint by the kids. The complaint comes from the parents, the school, the society. And so there is a real ethical point about, is this kid a patient or a disease? And I have no answer at the moment. I have no answer because, as I told you, there is a risk of death due to accident after. We have to take ADHD into consideration. But when we see the patient is curious, he is fine, he is happy. The second point is, do you know what is the main side effect of stimulants? Appetite, sleep, blood pressure, tics? No. The main side effect of stimulants is that they are medication. And thus, if you have a kid in front of you, well, of course it will be easier for you. But for me, I am a child adolescent psychiatry. If I say, okay, I will prescribe a medication, I say immediately, your kid has a mental disorder. And this is official because I give to him a psychotropic drug. And I am a psychiatrist. And when you say to somebody, you have a mental disorder, your life is no more the same. And this is true when they are 5 years up to 70 years old. You will know all your life that at a given moment in your life, you have been labeled as a person with a mental disorder. And in the very day-to-day life, when you have during lunch, for instance, the two parents who are struggling, and it happens, of course, and the kids see the parents struggling, and the kids agitate, of course, and the parents will say, stop, you have ADHD, don't bore us, it is because of you that we have problem, etc. This is so simple to say that the problem comes from the kid, because it is official, the kid takes medication. So this is official, he has problem, and the problem does not come from the family. So there is also a question about the problem of prevalence of prescription. Why this increase of prescription of stimulants in our society? Perhaps because we recognize the disorder, and so this is a good thing, perhaps. And I'm sure this is in part true. This is in part true, but there are also other arguments to explain this increase. First, you have surely noticed, and sociologists have pointed that in our societies there is a higher and higher necessity to have a high level of self-control. And this is even more true for kids. This is very important to control ourselves. If you cannot control yourself, you are put apart the society. And of course, if you are impulsive, this is difficult to control yourself. And so this can explain why the impact of ADHD is perceived on a more sensitive point of view than before. And the other point is about authority. You know also that in our European and North American country, we have a question about authority, in particular about authority with kids. Because we are in postmodern societies and we have to be something, we have to realize ourselves, we have to have no limit in what we can become. And when you have no limit, this is very difficult to promote
Don't worry, it not that long.
It was a Caesar. 5 minutes, okay. Okay, I'm fine. Just one slide left. So there is a question of authority, and when we have difficulties to promote authority, of course, it is likely. I say it is likely, but because I have not found any papers on this point. Perhaps they exist, I have not found them. Perhaps because there is less authority, kids are more prone to engage in hyperactivity or impulsive behavior. And there is also a question about some colleagues who say, well, in fact, ADHD, it is a cognitive problem in the treatment of information, in data processing. And in fact, myopia, it is exactly the same thing. I am 26 minutes. Okay. So, in fact, ADHD is just like myopia. And sometimes I say that to my adolescents with ADHD. Well, in fact, you don't want to take your drug, but you have glasses, so it is the same thing. So they say, no, because when I have glasses, I can put my glasses out. When I take a pill, I am different. My experience of life is different. And because I am in a German-speaking country, I spoke about the Dasein. So this is my conclusion. We have powerful tools, a hammer, and a good diagnosis. We can do good. We can treat patients. We can change their life. And this is very good. But we can do harm. And we are caught within numerous paradoxical demands. People ask us to increase performance, but this is not our job to increase performance. Our job is to treat patients who suffer. So, to conclude, we have a fascinating job. This is very difficult to struggle with that, even when you consider that we have most often for our consultation 20 to 30 minutes. Thank you for your attention.